podcast is for educational and informational purposes only. It is not medical advice, legal advice, or professional advice of any kind. And it does not create an attorney-client, physician-patient, or other professional relationship. Any discussion of cases, outcomes, standards of care, statutes, or regulations is general in nature, may be incomplete, and may vary by jurisdiction and over time. Listeners should consult their own attorney, malpractice carrier, risk manager, or qualified clinician for advice on any specific matter. Any case discussions are based on public records, de-identified information, or educational reconstruction. The views expressed are those of the speakers and do not necessarily reflect the views of any employer, hospital, health system, insurer, or affiliated organization. Welcome back to On the Record from the Chartered Defense. This is episode 3, the season finale. Over the first 2 episodes, we laid out the medical story, the patient, her diagnosis, the pharmacology of warfarin, Coumadin, versus DOACs in antiphospholipid syndrome, and the severe clinical decline that followed. Today, we are going to do something different. We do not have the final outcome for this case scenario, but we are going to reconstruct what the experts for the plaintiff and defendants would allege at trial, and then discuss how a jury would decide the fate of this case if it were to make it to a jury. Many cases end well before the trial, either through settlements made prior to trial or summary judgment, which we saw in our first season's case. There are some available public opinions from the courts on similar cases. We are not doing a procedural play-by-play, and we are not predicting any ultimate verdict for our scenario. For educational purposes, we are focusing on 2015 being the year this patient was treated with a DOAC in place of warfarin, and how the experts would attempt to define the standard of care for a patient with APS at that time. Before we start, I'll summarize what we know about our patient. She was a young woman who developed a pulmonary embolism that was unprovoked. She had a workup with a hematologist and was found to have antiphospholipid antibodies as well as a prothrombin gene mutation and 1 additional gene mutation that can increase clotting risk. She was started on warfarin when this event happened, and about a year later transitioned to rivaroxaban Xarelto, as the frequent blood work and office visits for INR checks had become difficult for her. The patient was switched to rivaroxaban after discussion about risks and benefits. A few months later, the patient had a large hemispheric stroke and was found to have an aortic valve thrombus. This stroke left her significantly debilitated, and she subsequently died. The 2 questions at the center of this case are straightforward to ask and difficult to answer. In 2015, did switching this patient from warfarin to rivaroxaban depart from the accepted standard of care? And if it did, was that departure a proximate cause of her injuries? We will hear the plaintiff's expert first, then the defense experts. Then Michael will close with what physicians should take away from this case. The plaintiff retained an expert hematologist to testify on both standard of care and causation. Here is the strongest version of that testimony, grounded in the literature available as of 2015. The plaintiff's expert would begin with a firm proposition. Warfarin was the gold standard, front-line medication for thrombotic antiphospholipid syndrome. Not merely one acceptable option among many. The accepted standard. And for a patient with APS, a prior pulmonary embolism, and other prothrombotic features in the chart, the plaintiff's expert would characterize her as a high-risk patient in whom the burden of justification for replacing warfarin with rivaroxaban was especially high.
That language matters in a courtroom. Gold standard and frontline are not casual phrases. The plaintiff's expert is trying to establish that warfarin was the default therapy and that moving away from it required a very strong evidence-based reason.
What literature was available to physicians at that time? The 2015 RAPS protocol described long-term vitamin K antagonists, such as warfarin, as the current mainstay of treatment for thrombotic APS. A French multi-center observational cohort from the same era described VKAs, warfarin, the same way. And the older randomized evidence on warfarin intensity, Crowther in 2003 and the WAPS trial in 2005, supported standard intensity warfarin rather than a more aggressive INR target for most APS patients with prior thrombosis. So the plaintiff's expert starts from a stable premise. In 2015, long-term VKA therapy remained the mainstream standard for secondary prevention after APS-associated venous thromboembolism. Then the plaintiff's expert would turn to the DOAC literature, specifically rivaroxaban, and make a chronology point. The published RAPS trial results did not appear until September 2016. They were not available to support the 2015 switch, and they were not available to support the later continuation decision either. So the plaintiff's expert would judge those bedside decisions using only what was actually available at the time.
That chronology matters. If a later trial becomes the centerpiece of your defense, but that trial had not yet been published when the prescription was written, you have a timing problem. The defense would be prepared to counter that statement. As we have said, you can't look back with hindsight. You have to use the information that was reasonably available to a physician at that time.
The plaintiff's expert would then walk through the warning signals that already existed before 2015. In 2014, a Mayo case series described 3 APS patients who had been stable on warfarin and then developed thromboembolic events after being switched to dabigatran, Pradaxa, or rivaroxaban. The authors advised caution with DOACs in APS patients outside a clinical trial. Then, in 2015, another case series reported 8 treatment failures in APS patients on rivaroxaban, including arterial events in several triple-positive patients. That paper said DOACs should not be recommended in APS until trial data were available, and still described VKAs as the agents of choice and the mainstay of therapy. The plaintiff's expert would concede that some favorable early reports also existed. A French multi-center observational cohort of 26 APS patients reported that DOACs were often introduced because of INR lability or therapeutic simplification, and concluded they might be an alternative. A small 8-patient case series published online in early 2016 reported no recurrent thrombosis during follow-up and called DOACs a rational alternative. But the plaintiff's expert would emphasize 2 points. Those studies were small, and even the favorable early 2016 case series explicitly stated that DOACs were not the standard treatment in APS.
So the plaintiff's picture is this: there was interest in DOACs, but not much in the way of evidence to support their safety and efficacy for patients with APS. and that a careful review of all the available literature would support warfarin as the clear standard of care treatment.
The plaintiff's expert would also argue that the literature was not simply uncertain in a neutral way. It already contained papers raising real concern about treatment failure and arterial events. So the criticism would be sharper than, "I would have done something different." The criticism would be, "You were aware, or should have been aware, of cautionary literature and still chose the less established drug." On patient preference, the plaintiff's expert would draw a hard line. The reason for the switch, according to the record, was practical difficulty with INR monitoring in a young woman. The plaintiff's expert would say that convenience alone did not justify moving a high-risk APS patient from the accepted standard to a novel off-label option with mixed and limited data. Shared decision-making matters, but in this framing, it does not erase the physician's duty to recommend the treatment best supported by the evidence.
We will come back to this at the end of this episode because I think this is a really good point of discussion. How do the courts view shared decision-making? More importantly, how do the courts view shared decision-making if a patient strongly prefers the new, less studied medication? Again, I don't know if the patient was strongly against continuing warfarin. I'm just phrasing it this way so we can think through what our decision would be if we were taking care of a similar patient. The request from such a patient would not be unreasonable. That is an uncomfortable but important point for physicians. Patient convenience is clinically relevant. Quality of life matters. But the plaintiff's expert would say there are situations where the physician still has to say, "I hear your concern, but this is the safer, better supported path, and I recommend it." This is, again, the plaintiff's expert opinion on this issue. We will see how the defense's expert frames this issue shortly.
Now the plaintiff's expert turns to causation. Sarah, what does the plaintiff have to prove?
The plaintiff has to prove by a preponderance of the evidence that the prescribing decision was a proximate cause of the injuries. Not absolute certainty, not mathematical proof, but more than speculation. Ours, the expert has to connect the drug choice to the outcome in a medically coherent way.
The plaintiff's expert would offer a focused causation theory. The theory would be that warfarin was the most effective medication to reduce thrombosis risk in a patient with this profile, and that if the patient had remained on warfarin or been switched back to warfarin before the stroke, the aortic valve thrombus would have been less likely to form, or at least less likely to become as large and embolize. In other words, the plaintiff does not need to prove that warfarin guaranteed a perfect outcome. The plaintiff needs to prove that the better supported anticoagulant, more likely than not, would have reduced or prevented the specific injury pathway that occurred.
That is an important distinction. The plaintiff's expert is not saying warfarin is magic. The claim is narrower. In this patient, at this moment in the literature, warfarin was the more protective drug, and abandoning it materially increased the likelihood of the catastrophic outcome.
The defense retained expert hematologists to testify that the treating physicians did not depart from accepted medical practice, and that even if they did, the plaintiff cannot prove that the drug choice caused the injuries. Here is the strongest version of that testimony. The defense experts would begin by reconstructing the clinical environment of 2015. DOACs had been widely adopted across medicine. Rivaroxaban was FDA, approved for treatment of deep vein thrombosis and pulmonary embolism and for reduction in the risk of recurrent DVT and PE. It offered fixed dosing, predictable pharmacokinetics, fewer food restrictions, and no routine INR monitoring. For a young mother struggling with repeated monitoring visits, those features were clinically meaningful. The defense would not say warfarin was irrelevant. The defense would say warfarin was the established therapy, but also an imperfect, burdensome one. It has a narrow therapeutic window. It interacts with diet and other medications. And in APS patients, lupus anticoagulant can complicate INR interpretation. So the defense theme is not that warfarin was a bad drug. It is that, in real-world APS management, physicians had understandable reasons to consider alternatives when monitoring burden or monitoring reliability became a problem.
I think this framing from the defense expert is strong. Warfarin can be standard and still be difficult. If you are defending the switch to rivaroxaban, you argue that the doctors were not chasing novelty for its own sake. They were trying to solve a genuine management problem. And what if a patient might decide to stop taking anticoagulation altogether because of that burden?
The defense would then make its own chronology argument. They could not lean on the RAPS results suggesting rivaroxaban as non-inferior. Instead, the defense has to lean on what was actually available then. The RAPES protocol, the small French cohort, the small 8-patient case series, and the broader clinical experience of DOAC use in venous thromboembolism. The defense would say those sources showed that rivaroxaban was an emerging, evidence-informed off-label option for selected APS patients with venous disease, not a forbidden drug. The defense would also emphasize that RAPS was underway at the time, which matters conceptually even if the results had not yet been published. The very existence of a prospective randomized study in APS signaled that serious clinicians believed rivaroxaban was a legitimate question worth testing in this population. In the defense view, that does not prove rivaroxaban was the standard. It supports the narrower claim that reasonable hematologists could disagree in 2016 about where the field was heading.
And that is the legal hinge. In a malpractice case, off-label prescribing is not negligence by itself. The question is whether the choice fell outside the range of what a reasonably prudent physician in the same specialty could have done under the same circumstances, using the evidence available at the time.
The defense would press that point hard. Rivaroxaban was off-label for APS, yes, but off-label prescribing is common in medicine, especially in uncommon conditions where large definitive trials lag behind practice. The defense would say this was not reckless experimentation. It was patient-specific, literature-informed, off-label prescribing in a gray zone. On shared decision-making, the defense would present a very different story than the plaintiff. According to the defense, the patient asked to switch because INR visits had become difficult. According to later testimony summarized in the court opinions, the specialist told her there were more data on warfarin than rivaroxaban, but she did not want to consider warfarin. The defense would argue that listening to those preferences after counseling was not negligent care. It was patient-centered care.
And the defense would remind the jury that the legal standard is not, did the doctor choose the single best option in hindsight? The question is whether the doctor chose an option that fell within an acceptable range of professional judgment at that time.
Now the defense turns to causation, and the defense would argue this is where their case is strongest. The defense hematology expert would testify that the plaintiff's injury mechanism was not meaningfully altered by choosing warfarin over rivaroxaban. In that expert's view, anticoagulant choice would not prevent the development of the thrombus that developed on the valve. So the sequence that led to the stroke was not a drug choice phenomenon. That is the defense causation theory.
If a jury accepts that theory, the causation element becomes very hard for the plaintiff, because then the case is no longer wrong anticoagulant caused the stroke. It becomes the disease process caused the stroke, and the plaintiff cannot prove a different anticoagulant would have changed that.
The defense would also emphasize a basic clinical reality. Recurrent thrombosis can occur despite therapeutic warfarin in APS. No anticoagulant guarantees protection in a disease defined by breakthrough clotting. The defense point is not that the outcome was inevitable. The defense point is that the plaintiff still has to prove that warfarin, more likely than not, would have prevented this specific event. In a severely prothrombotic patient, that is a demanding causal burden. So the defense frames the case this way. This was a severely clot-prone patient with aggressive disease biology, a difficult anticoagulation problem, and no perfect option. The plaintiff frames the case differently. There was a better supported option, and the doctors moved away from it without adequate justification. That is why this case becomes a battle of expert weighting and interpretation, rather than a simple yes or no pharmacology question.
So we now have the strategy of both the plaintiff and defendants. Both sides make compelling arguments in their attempt to define what the standard of care was at that time, and maybe more importantly for the defense, tried to show that the drug choice would not be a proximate cause of injury and death, because the aggressive nature of the disease itself can and does cause blood clots and thromboembolic events even when therapeutically anticoagulated. How would a jury make sense of all of this information? That can be a very difficult task. The judge will provide jury instructions and lay the process out for them. If you were a juror, what side would you agree with more? Who makes the better argument? Let's look more into the standard of care argument and then talk a little about the shared decision-making process and its potential role in litigation.
Sarah, what happens when two qualified hematologists look at the same literature and reach opposite conclusions?
Our first case ended at the summary judgment stage. In this case, the trial court found triable issues of fact on standard of care and causation. It is a recognition that qualified experts disagree in a way a jury may have to resolve. Therefore, the motion for summary judgment by the defense was denied here.
Michael, put the medicine in context for us. What was the standard of care landscape actually like in the time around 2015?
2015 sits in a genuine gray zone. Warfarin was the established mainstream standard for thrombotic APS. But the relevant clinical question here was secondary prevention after a prior pulmonary embolism in an APS patient, not treatment of a patient with known prior arterial APS. And the early defense-friendly literature was aimed mostly at venous APS. At the same time, the favorable DOAC data were small and warning case series already existed. So the legal question becomes very precise. Was the uncertainty broad enough that reasonable physicians could still disagree? Or were the warning signals strong enough that a prudent physician should have defaulted to warfarin?
And that is why both sides can cite real papers and still land in very different places.
Exactly. Same studies, different weighting. The plaintiff says the cautionary papers should have controlled. The defense says the field was evolving and no definitive prohibition existed in early 2016. That is why these cases are hard, and that is why courts are often reluctant to dispose of them on paper alone.
Michael, what do you want physicians to take away from this case?
I want to start with restraint. I was not in those exam rooms. I do not have every page of the chart. I am not here to assign blame. My purpose is narrower, identify the decision points that matter, and extract lessons physicians can actually use. Lesson 1. This is no longer the same gray zone it was in 2016. For thrombotic APS, warfarin remains the preferred anticoagulant, especially in triple-positive disease or arterial disease. Current FDA labeling for rivaroxaban, apixaban, Eliquis, and dabigatran states that these DOACs are not recommended in patients with triple-positive APS. That is not the same as a blanket all-APS prohibition, but it is a strong warning, and it is much clearer than what clinicians had in front of them in 2015. Lesson 2, phenotype matters. Venous APS is not the same as arterial APS. Triple-positive APS is not the same as a lower-risk antibody profile. If you are making an anticoagulation decision in APS, you need to know exactly what phenotype you're treating, and your note should make that explicit. Lesson 3, if you depart from the mainstream standard, document the reason with precision. Was the problem INR burden, INR lability, suspected lupus anticoagulant interference, recurrent thrombosis despite therapeutic warfarin, major bleeding, patient refusal? Your chart should show the problem you were trying to solve, the alternatives you considered, the literature or guideline logic you relied on, and the counseling you provided. Lesson 4. Patient preference has limits. Shared decision-making is essential, but it does not relieve the physician of the duty to recommend the option best supported by the evidence. If a patient asked for the more convenient path, and you think it is also the riskier path, say so plainly and document that conversation. Lesson 5. Care coordination matters. In this case, one physician changed the anticoagulant and another later continued it. When care passes from one specialist to another, each note should show whether the prior rationale was reviewed, whether the full risk profile was resynthesized, and whether anyone reconsidered the plan in light of the whole case. It looks plausible that this happened in our case, so even coordinating care does not guarantee that you will not find yourself in this type of situation. Lesson 6. Understand how your chart will be read years later. In litigation, your note becomes evidence of what you knew, what you considered, what you warned about, and whether you recognized uncertainty. A vague note invites reconstruction by someone else. A precise note is your best contemporaneous witness. And one more point, do not let any of this push you into fear-based medicine. The goal is not to practice defensively in the caricature sense. The goal is to think clearly, know the evidence, communicate honestly, and document why your decision made sense at the time you made it.
That brings us to the end of Season 2 of On the Record. Over these 3 episodes, we traced one patient's journey. From a pulmonary embolism, through a complex diagnosis, a disputed anticoagulation decision, and ultimately a severe clinical outcome. Today we focused on how that medical story becomes expert testimony on standard of care and causation. We are not predicting any final outcome in this case. The educational value is in the gray zone itself. Pre-TRAPS prescribing decisions were made in a moving evidence base. Later trials and label warnings clarified the terrain. But the bedside decisions in 2016 were made before that clarity existed. That is precisely why the case teaches so much. Before we sign off, Sarah, let's do one short practical Q&A. Physicians hear shared decision-making all the time. In malpractice terms, what does that actually mean?
Shared decision-making is a process, not a magic phrase. The physician explains the medical problem, the reasonable options, the material risks and benefits, and the areas of uncertainty. The patient explains what matters to them: monitoring burden, side effects, cost, caregiving, quality of life, fear of bleeding, fear of clotting. The final choice is collaborative, but the physician still owns the recommendation.
So where does shared decision-making usually show up in a malpractice case?
Most often in informed consent, informed refusal, or failure to warn claims. In other words, did the patient actually hear the recommendation, understand the alternatives, and appreciate the major risks? That is where a good shared decision-making note can help the defense. It is much less powerful if the plaintiff's central claim is that the doctor chose an option outside the range of reasonable medical practice.
So does it help your defense as a physician?
Yes, but within limits. A strong shared decision-making note can be very helpful if the allegation is, "Nobody told me," or "I was never offered the safer or more established option." It can show that the patient was informed, asked questions, and made a values-based choice. But it is not a cure for a substandard decision. If the treatment itself is later shown to be outside the reasonable standard of care, consent does not rescue it.
That sounds like the difference between informed consent and standard of care.
Exactly. They overlap, but they are not the same claim. Informed consent asks whether you disclose the material information a reasonable patient would want to know. Standard of care asks whether the treatment choice itself was professionally reasonable. A physician can win the disclosure argument and still lose the standard of care argument.
And for a high-stakes medication decision like this, are we really talking about a classic consent form?
Usually no. For medication selection, what matters most is often a contemporaneous shared decision or informed refusal note in the EMR, not just a checkbox form. A signature proves that paper changed hands. A note shows what you recommended, what the patient declined, what risks were discussed, and why the final plan made sense at that moment.
So if you are writing that note in the chart, what would you document?
I would consider these 9 things. 1. The diagnosis or working diagnosis and the exact decision being made. 2. Your recommended option and why you recommended it. 3. The reasonable alternatives, including continuing the current plan, switching therapies, and in some settings, no change or no treatment. 4. The material risks, benefits, and uncertainties of each option, especially the serious, patient-relevant ones. 5. Whether the use is off-label, evidence-limited, or guideline-supported. 6. The patient-specific factors driving the discussion: prior thrombosis, prior bleeding, pregnancy history, transportation barriers, INR burden, cost, adherence concerns, or caregiving constraints. 7. The patient's questions, stated priorities, and final preference. 8. That the patient had decision-making capacity, or that a surrogate participated, and that understanding was confirmed. 9. The follow-up plan, return precautions, and what would trigger reconsideration of the decision.
What if the patient is declining the option you think is better supported?
Then say that plainly. Document it as informed refusal of the recommended option. Write what you recommended, why you recommended it, what the patient declined, and the specific risks of declining that recommendation. Patient prefers Xarelto is weak. I recommended warfarin because Zhao Zhang reviewed the reasons, discussed the risks of declining warfarin, and the uncertainty surrounding rivaroxaban in APS. Patient elected rivaroxaban after discussion is stronger.
What is the sentence physicians should stop writing?
Risks and benefits discussed, and also patient requested it, standing alone. Neither tells a later reader what you actually recommended, what alternatives were offered, or whether the patient was informed about the hard parts of the choice.
And the bottom line?
Shared decision-making is real, important, and defensible when there are genuinely reasonable options. But it works best as evidence of a careful process, not as a substitute for good medicine. In the chart, document the recommendation, the alternatives, the material risks, the uncertainty, the patient's values, and the follow-up plan. That is what helps the next clinician, and if necessary, your defense.
Thank you for joining us this season. My sympathies go out to this patient and her family. It is such a tragedy for anybody to die at such a young age. I hope we all can learn from going into these cases so that we can decrease or eliminate those outcomes that might be preventable. We will be back with our Season 3 case soon.
Until then, thank you for listening to On the Record from the Charted Defense.